again, we've got me talking about fatigue and memory loss. So trying to cover both of those things, I suppose, because I'm an occupational therapist by background and because they are two of fairly commonly discussed symptoms. We've talked about them throughout the day. They are linked. There can be links. Both of them can be transient. Both can be permanent. Both have a number of possible causes. So both can respond to treatment and interventions. And there are effective coping strategies and compensatory techniques for both. So that's why they're linked in together and why I'm talking about both of them. Just a little bit briefly about cancer-related fatigue. In general, for all cancer groups, I think a few years ago, 10 years ago, we'd be saying underreported, under-acknowledged, all of that. And I think actually in 10 years we've got loads better about talking about it. It doesn't really make it any easier to treat, although we're asking about it more. It's on your holistic needs assessments. It doesn't mean we're sort of much further on in treating. So when does it become a problem? And it becomes a problem when there's a bit of a discrepancy between what a patient wants to do and the energy that they've got to do it. And it might cause their families to miss out time with them on journeys, on trips, on special days and things like that, and experiences together when those experiences are going to be really important. The other time when I think, like Charlotte touched on it really well earlier on, is when people are going through treatment, so especially radiotherapy, they're told to expect fatigue and they can manage that in the short term. And I think that because they're expecting to feel tired, it's not too much of a problem for them. But it's when it continues beyond the treatment phase that I think people struggle. Causes of general cancer fatigue, which can be very, very varied, as we've discussed. A lot of these we have discussed throughout the rest of the day, and we'll go through them a little bit more in detail. But why is it more complicated with brain mets patients? And again, we've discussed a lot of these. It's more complicated because they have radiotherapy to the brain, and that does make people more fatigued. They've got maybe neurological disorders. So actually doing something with a weakness or a cognitive problem or a visual problem takes more energy than it would do for somebody without those problems. So you're actually using up more energy in your normal everyday tasks. Epilepsy meds, as we said before, can cause people to be more fatigued. Endocrine dysfunction, which is one of the late effects of radiotherapy, can make people feel more fatigued. Sleep disturbance, and then just a gradual deconditioning over the years of having a long-term condition. So really what we're here about is what can you do about it? So we know we've got specialists in the room who are going to look at this in more detail, but for the general population of cancer professionals, everybody, what can you do about it? You can ask questions about it. There was some interesting research done on the effectiveness of modafinil. Have I pronounced that correctly? Modafinil. And what they found was the control group that weren't receiving the drug actually responded equally to the drug group, and they thought that it might have had something about somebody actually asking the question about the fatigue and focusing on it. And again, remembering that it's relative. So somebody who used to run marathons, who could now only walk 2 miles, that's devastating for them. But in the scheme of things, compared with somebody who's bedbound, for the community services, that's not going to trigger a lot of input, but for that person, that's devastating. So it's understanding that level of distress it's causing them. So these are example questions that you could ask that will help you get to the bottom of what the fatigue is, where it's come from. Is it transient? Is it treatment related? Is it going to, is this kind of stubborn chronic fatigue that they've lived with for 3 years now? Or is it something that's only come on in the last 2 weeks since they finished their radiotherapy? And you need to understand what it means to them. So how does it affect you as a person? How does it affect your patient? You can get people who can just plod through their everyday things and do okay, but cognitively they feel rubbish and their memory's very, very poor because of it. Or you can get people that are really struggling emotionally with it, and you should understand the issues as well. So that's what you can do about it. So you've asked those questions to identify what you can, what the issues are. And then this is the bit where I suppose it could split both ways. Do you have the skills to help that person? So in all the questions that you've asked, can you identify any treatable, reversible causes? So depending on your profession, that will be really different for everybody. So if you're a medic, could you do any blood tests, identify any anemia? Could you do a pain scale and identify some pain relief that might help somebody and get them better sleep? Could you give basic dietary advice? Is the person eating enough fuel? Are they consuming enough calories to give them the energy? So they're really easy things that we can do before we need to go any further. We can also, this is the OT's secret, I think OTs are ready to share this now, PPP, which is pacing, planning and prioritising. And it is really good for patients to remember PPP, so they can pace themselves, they can slow themselves down. Don't approach everything at 100 miles an hour, as a lot of people do. Plan, so plan your week, plan your day. Book things in the diary. Don't book loads of things on the same day and then have 3 days off. If you have got a really busy day, don't plan anything the next day, because you probably will feel a bit rubbish the next day if you've had a massive family party the day before. But you can plan that in your diary. If your patient gets good at this, they can do it. And prioritise. So if you really don't have enough energy to do all those things that you need to do in a day, then you get somebody else. I always laugh with people and just say, if you don't want to do the ironing, get somebody else to do it. If you don't want to do the dishes. But some people thrive on doing the ironing and ironing the kids' school uniforms on a Sunday night before a Monday. So to them, they wouldn't give that task over to somebody else. That's important to them. More complex interventions, I've given you a link there, but above 3 on a rating scale of 1 to 10, they should be referred for more complex intervention. And these can be obtained from various, depending on your resources around your area, various different people. So you can do education, information, you can do pharmacological through GP, CNS, consultant, nutritional intervention if it's more complex from a dietitian, graded exercise through physio, sleep and relaxation, OT, from psychology, from CDs, energy conservation and restorative activities from OT, psychological support, and even cognitive behavioural therapy for fairly stubborn fatigue that people are really, really struggling with. So memory. Not as long on memory, and memory is actually a bit more tricky. But the basics for memory, people overuse the word memory, they don't always mean memory. So it's worth asking the questions and find out exactly what they mean. Some people will tell you that they've forgotten the word. So some people might describe word finding problems, so speech problems, as a memory problem because they've forgotten the word, and we'd class them as very different. So is it remembering tasks and appointments? Are they becoming distracted and not finishing jobs, or forgetting what's been said to them? There are 3 different types of memory there. But a basic checklist: fatigue, pain, stress, and endocrine dysfunction can all affect memory. So that's a kind of a basic checklist, things that we can do stuff about. But one thing that you can all recognise and take away from this is that attention or concentration or focus, whatever you want to call it, but we'd call it attention, is the beginning part of memory. So when people tell you they can't remember what's been said to them, it's worth giving them a little bit of a pep talk about the fact they have to concentrate or focus on what's being said in order to put it in as a memory. And quite often, with the pain, the fatigue, and drugs, whatever else is going on in somebody's life, it's the beginning bit that they're missing. And sometimes it can be a bit of a quick fix, that you can do things and help people understand that beginning part of the memory process that they can actually help with. So they can use basic techniques such as reducing the background noise, turning the TV off, not trying to do two things at once, divided attention. Again, you could do a whole day on this, but the more things somebody's trying to concentrate on one time, the less likely they are to be able to do it. So if they only have to focus on one thing at the time, they're more likely to succeed. And the other thing is repetition, to encode it, to get it in your brain. So even just teaching people a general phrase like, let me check, I've understood what you've said, or did you just say, I've got a meeting at 3 o'clock, or whatever it is. But just the feedback loop of repeating it, make sure they've got it right and they've heard it the first time, but it also helps them get it in their memory. It's very, very basic, but we're not going to be able to solve memory problems for everybody if they're complex memory problems, but that's something that you can do. Signposting, again, is really, really difficult for memory problems because you need to know what the cause is, I suppose. You need to know that who to refer to in your area. So you need to know what local resources you've got. Neuro OTs, again, if you've got the neuro teams available in your area, neuro-trained OTs can really help with the functional, practical memory stuff. Some dementia services will have the skills to deal with the practicalities and the emotional support for family. So you could try and dip into dementia services, but you've got to do that with their knowledge. I phoned one the other day. I didn't realise it was a dementia service. It just said memory clinic. And I phoned them and they went, oh no, we don't do that. We just tell people they've got dementia. I was like, okay, so that's not going to work. So it's local resources. But neuropsychology, if available, can help. And they can help and give you advice as well.